Dear friends, have a nice time where you are. I am Dr. Mohammed Al-Rawhani, consultant nephrologist in UAE. My talk today about the management and challenge in the management of heart failure with CKD, chronic renal failure, in patient who need to reach the maximum tolerated dose of medication. As we know, all of us, that there is 4 now player, the RASI blocker, including the ARNI, and beta blocker, and mineral corticoid agonist, MRA. These 3 medication with SGLT2 inhibitor are essential in the treatment of heart failure. And we know that the up titration will start within 1 month and a half maximum to reach the maximum tolerated dose, which mean that these dose, they are that what we can have them to have the maximum beneficial effect without side effect. And one important side effect with heart failure, especially patient with CKD, is the hyperkalaemia. Hyperkalaemia will lead us to down titration or holding the medication with losing the benefit of the use of the medication. Except SGLT2 inhibitor, they have mild effect on reducing potassium, so we are a little bit in the safe side with them. In this way, I can tell that first of all, we have to look to the mechanism that will integrate it between the heart failure and CKD and lead to the development of end-stage renal failure. Why these? Because it is important to put in our mind how important we have to maximize this medication. We know that there is some situation where we have either overload of chronic pressure in the kidney and the heart as well, and we have overload fluid in the volume in the heart also, and we have clinical situation or clinical definition of ischemic or non-ischemic disease of cardiomyopathy, what will lead slowly to the progression of heart failure and also affecting the function of kidney. In general, we can speak there is a cardio-renal syndrome with all the package of the cardio-renal syndrome and the integration of that. And with that, we cannot forget the risk factor like diabetes, like obesity, like poor outcome of fitness and activity. We have not to forget anemia and mainly iron and deficiency and iron deficiency anemia and the effect on the heart failure and the ischemic level of in the human body. Also, we cannot forget the type of the renal failure, heart failure, which can lead to deterioration of estimated GFR and mainly with reduced ejection fraction. And for example, ischemic heart disease, for example, cardiomyopathy, dilated cardiomyopathy, and low cardiac output cardiomyopathy, mitral valve disease, aortic valve disease. All these can lead to something called symptomatic heart failure, that means reduced ejection fraction heart failure, deterioration of the kidney function, that is slowly deterioration of the estimated GFR, of the GFR evaluated by the estimated GFR, and that will lead us to the issue of development of deterioration of renal function, need of the end-stage renal failure, renal replacement therapy, and these all will be in the sad side of the patient. We have to remember that the relationship between heart failure and CKD depends on which stage we are. When we are in CKD stage before the renal replacement therapy, we have worse outcome. The difficult and more worse outcome is appearing when we have hemodialysis. Between the CKD and the hemodialysis group of patients, we can find that the peritoneal dialysis is having a good outcome, mainly for the development of heart failure, and the best one, of course, of the kidney transplantation. So, patient with CKD and hemodialysis are at a risk of development of bad event, side effect, readmission, deterioration of quality of life, and sad outcome if, with an increase of mortality. And this increase of mortality is really depends how we can increase our level of care in maximizing the dose of MRA, of RASI blocker, of beta blocker. In these, we will take every group alone in separate video to discuss how it is important to have this medication in the maximum tolerated dose, to have the benefit of cardio-renal protection, to reduce the mortality and to reduce the development of end-stage renal failure, to reduce the albuminuria and proteinuria. It is an important and a big issue, and of course are blocked by the side effect, mainly hyperkalaemia. Thank you. I hope you will follow the second video, and I hope you enjoy it. Thank you so much.